Ready?
Yes, sir.
All right, nurse is caring for a client with unstable VTAC. Unstable VTAC is different, right? So the nurse instructs the client to do which of the following, if prescribed during an episode of VTAC. Hold on a second.
Valsalva remover first.
So ready? I'll give you some, well, that's kind of the point.
Oh,
So your answer,
sorry.
your answer choices are breathe deeply, regularly, and easily, lie down flat in the bed, remove any metal jewelry, or inhale deeply and cough forcibly for 1 to 3 seconds.
Inhale.
Yeah.
Yeah, but bearing down is obviously the,
There is one where she said that, it's like the only one that you would do if like, you're like using the bathroom. Remember? She said that's the only time you'd be able to like bear.
VFib.
Or the bear down?
Yeah, like while you're using the bathroom. She said like go forward, like
Mm-hmm.
pretend you're using the bathroom.
That's VFib, right?
It's, I don't remember,
Or
but I know
either
that.
VFib
That's
or
to get you back to a normal rhythm.
Yeah,
Or-
there's like one of them that she said.
Or a flutter?
SVT
Oh,
also just tell them, if you're down like you're gonna poop.
That's
Yeah.
because I don't see that here.
Oh, okay.
This
I
is
see
the
it, sometimes I
right?
can break it.
Oh.
As an unstable patient with articles.
Yeah, the
That was a
Valsalva
question anyways.
maneuver. Yeah.
It's unstable. So what are we gonna do?
All right,
And they have I like some of the options.
should we wait for Mary for that?
Sure.
Yeah, we can wait.
So, VFib is like one of the dead ones, right?
Yeah, VFib, VTAC are, both of them.
And then asystole is the one that's like
Asystole is flatline.
flatline.
There is no cardiac activity.
Like it only has like one little UR,
Yeah.
but it's done. Like it's just,
And it's hard to bring them back from that.
Mhm.
Or you
It
can't,
doesn't
right?
mean it's impossible. You try to, you keep your algorithms going, you keep doing your math, happy. And sometimes when, with asystole and PEA, they're kind of the same thing where you kind of figure out the H's and T's. It's like, is it like acidosis, or
yeah.
is it all this different stuff? To be honest with you, most codes you want to give them bicarb anyway, only because the carbon monoxide builds up. Period.
Because they're not breathing.
Because they're not breathing it, right? So you need something to help, right?
If they're not.
So, like the kidneys.
Okay.
Sorry, I had a few.
Yeah. So I mean, like, you think about like metabolic versus like respiratory, right? So it compensates. Metabolic, if there's a metabolic issue, then your respiratory rate's going to be really, really high because it's trying to compensate to blow off the CO2 that's built up, right? That kind of thing. And then vice versa, with it being a respiratory problem, the kidneys wind up getting involved and through the renin-angiotensin system, so it's kind of like crazy. Try out how it works. But anyway, both cases you wind up doing bicarb anyway. All right, so here is the question. So client having treatment for ventricular contraction, VVC. And the nurse would place a priority in the assessment of which of the following items. So of this following assessments, right, what are we going to do? Blood pressure and peripheral perfusion, sensation of palpitations, causative factors such as caffeine, or precipitating factors such as infection. So clients have frequent premature ventricular contractions, so we're trying to figure out the cause. Why is that?
Caffeine. It's just caffeine.
Caffeine, okay?
What was the last one? BP, palpitations, caffeine. What was the
The
last one?
client is having frequent premature
Sensation of
ventricular
palpitations,
contractions. The nurse would place a priority in the assessment of which of the following. So basically, we would ask them questions such as pertaining or assessing the blood pressure and peripheral perfusion, sensation of the palpitations, if they can explain it. So the causative factors such as like things like caffeine, or precipitating factors such as infection.
It's a BP.
I
I
kind of
think
wonder
I
about
think it's the first one.
Blood pressure and peripheral fatigue.
Yeah,
Correct.
because that's the
Yeah.
most important.
Okay.
The reason why is because PVCs can cause hemodynamic compromise. The short ventricular filling time of the ectopic beat leads to decreased stroke volume. And then if frequent enough, it will decrease that cardiac output.
Intraventricular contract. So it doesn't
Yeah.
contract that.
Yeah.
Yeah,
Well,
if you
right?
think about it, right? If it's like, if
Yeah.
it's ventricular in nature, right?
Yes.
So reason if it's
It only took us 4
Oh,
seconds to figure that out.
PACs.
Atrial.
Yeah, pre-atrial contraction is different.
Yeah,
than
you're
PVC.
in line.
So it's just like, regardless if it was atrial or ventricular, the thing is the heart's not beating right, whether it's the top or the bottom, right? And therefore perfusion is going to be affected regardless of what is the cause,
Cause,
right?
yeah.
So that's the thing, so you know it's going to be that. So of course, conversely, their blood pressure and heart rate is obviously going to be altered, right? So I mean, that's a pretty good thing. But more importantly, capillary refill and stuff like that, that's how we can tell perfusion, right? So, all right, good job. All right, let's see. Client is developed AFib, and it has a ventricular rate of 150 beats per minute. And nurse assesses the client for what? What are you going to assess them for? And your options are flat neck pains, hypertension and headache, nausea and vomiting, or hypotension and dizziness.
Hypotension.
Right, we just talked about the same thing, right?
Mm-hmm.
Yeah, exactly. So the bottom line is you're not refusing, right?
Mhm.
And you know that's what's going on happening. So these are the things.
Hypertension. Something else. Okay.
Hypertension and dizziness.
Yeah.
Hypo.
All right, so now you're watching your patient on the cardiac monitor, and his rhythms is now suddenly changing. And you notice that there are no P waves. Instead, there are wavy lines. The QRS complex measures 0.08 seconds, but they're very irregular, with a rate of 120 beats a minute, so it's ventricular. So the nurse interprets the rhythm as what?
VFib? VFib. Wait, no. No P
There's
waves.
no P waves.
AFib.
No, there are P waves with a.
Could it be
AFib.
VTAC?
Because there's no P waves, so that's an atrial issue.
Right.
Unless
Right.
it's, so it's
Right.
a
It's
AFib?
atrial issue.
A flutter.
Okay,
I don't know.
it's atrial.
P,
So there, let's think about, listen to this again.
SVT?
There are no P waves,
No, you
Yes.
said it's A
right?
already.
There's no P waves.
No P waves.
It says that instead of the P waves, there are wavy lines.
Oh,
Oh, like the
it's
flutter.
VFib.
Then the QRS complex measures 0.08 seconds, but they're irregular. The rate of is 120
That's
beats
fast.
per minute.
Wouldn't that be the A flutter?
Oh,
Atrial
so
flutter?
isn't it AFib?
I think it's
That's
S.
it. It's atrial fibrillation.
Oh, it was atrial
Atrial
fibrillation.
flutter.
Oh, the definable P wave is this one.
Yeah, so AFib again is characterized by the loss of P waves. And
Oh, but it still has a QRS.
QRS.
wavy but based on this, but QRS, but they can be altered,
Mm.
right?
Because
They don't
it's
look, they don't
QRS.
look, they're not uniform.
With,
They're there, but they don't look
um,
uniform.
Yeah,
AFib.
but you know, we'll be able to see the
It's the second
actual
strip
EKG
on
on
the
next
slide.
time.
Was it that one? Okay, cool.
Makes sense.
It's a little bit harder when you're doing this verbal
Yeah.
right? So it's different. It's cool, but you're getting it together. So the client has a rapid rate or atrial fibrillation. So his AFib is rapid. Ask the nurse why the physician is going to perform carotid massage. The nurse responds that this procedure may stimulate what? Similar to what we were talking about earlier.
Valsalva?
Okay,
no,
so what
Vagal
is the-
stimulation.
Right,
Oh,
vagal
so-
stimulation, right?
Yep.
So what about it?
It would decrease the heart rate,
Vagus
Because
nerve
of
to
the
slow
vagus
heart
nerve.
rate.
Mm,
carotid massage, but we never do that.
not bilaterally.
Not
Yeah,
bilaterally.
well, it's the nurse here, it says the nurse responds, but the physician is going to.
Mm-hmm.
We're not supposed to, that's correct.
So.
So yeah, so the vagus nerve,
Vagus
they do it
stimulation.
so that the vagus nerve will slow the heart rate.
Slows heart rate.
Yeah, so the carotid sinus massage is one of the maneuvers used for vagal stimulation to increase the rapid heart rate and possibly terminate any tachydysrhythmia.
What was the one where you don't do a carotid massage because it could dislodge plaque?
You don't do both of them.
Well, I mean, if they need like a carotid endarterectomy, like you would never ever do that, because then it could dislodge that, and it went up with a stroke. Yeah.
I know what you're talking about though.
She said that in one of the slides.
I think it's you don't do both of them as a nurse.
Yeah, never bilaterally, and we don't do them as nurses. Period.
Somebody
But
else,
we
the
have
doctor
bilateral.
The doctor has to.
Huh?
The doctor
Oh
has
my,
to do
the what? I know I broke my shit on this one.
Vagus stimulation.
Wait till she comes back.
So if you have a patient,
If I
just
have a patient.
in real life,
Mhm.
that has AFib, would you go down the line of like treatments before you give the medication too?
So let's
in your
let's say
experience?
I bring my patient in. The patient comes in from the triage. They're complaining of chest pain,
Yes.
and I do an EKG and also put them on the monitor and I notice they're in AFib. One of my first questions for them is going to be, do you have a history of AFib?
Mm-hmm.
Because then it's going to take their variation. It's like knowing how to treat it and what comes next
Mm-hmm.
depends upon their history.
Mm. Okay.
Then the next component would be if it's super fast,
Mm-hmm.
you know, like in this situation.
Yes.
So if it's AFib, and then there's this one actually, that last question, the true answer is AFib with RVR. It's a rapid ventricular response. So it's just like, it's a little bit faster. You'll have the fib, and then the QRS complexes are much faster
Mm-hmm.
in between. So it's just like, it's not good to have that, because now the ventricles are involved.
Yeah.
So it's like, you know, so eventually what's going to wind up happening is they're going to wind up to go into probably the fib or the tach, and then go with cardiac arrest. You know, that's probably what's going to happen. So you really, rate control is really the most important thing for AFib
Mm-hmm.
and fibrinolytic therapy.
So what would you do first in that situation?
So
Like
if they've never been
treatment-wise?
diagnosed before with AFib and it's a brand new thing, then more than likely the doctor's going to probably give medicine to slow that heart rate down, and we don't always do like clot busting medications, because you're not really sure whether or not when it started.
Oh.
So then usually it's the cardiologist's call
Yeah.
to say, okay, yeah, well, let's put them in thinners, or they'll just take them to the cath lab and see what's going on.
So you don't do the vagus stimulation, Valsalva remover. You kind of just once you get them, you're like,
If I would not for AFib, for SVT, I would.
oh, okay, okay.
Yeah. All right. Everything good?
Yeah.
All right. So, a nurse notes that a client with sinus rhythm has a premature ventricular contraction that falls on the T wave of the preceding beat. So the client's rhythm suddenly changes to one with no P waves or any definable QRS complex. Instead, there were coarse, wavy lines of varying amplitude. That's correct. That's right.
Finally.
Anything that falls on the T wave will.
Good job. Yeah. So for those of you who didn't, maybe the answer was too fast, BFib is, once again, just characterized by irregular, chaotic rhythms or beats with varying amplitudes. Like some might be higher, some might be lower. And then also it has no measurable rate and no visible P waves or QRS complexes. Very really organized. Okay. while caring for a patient who has sustained an MI, the nurse notes 8 PVCs in 1 minute on the cardiac monitor. The client is receiving an IV infusion of D5W, also has oxygen at 2 liters a minute. The nurse's first course of action should be what? Increase the IV infusion, increase the oxygen concentration, administer a prescribed analgesic, or notify the physician promptly.
I've notified the physician.
I almost feel like you should do the oxygen.
Decrease
First.
oxygen?
Increase it?
Yeah.
No, you can't go over 2 liters of oxygen when somebody has a heart,
Oh, an MI?
a heart issue, like believe, I think that's what was on the factor.
Oh, I thought you could.
Because they're not, if they have 8 PVCs in a row, they're not getting perfused.
Yeah.
Oh, yeah.
There's no oxygen coming in at all.
True.
I'm between O2 and Notify MD.
Yes.
Just notify MD.
What's your gut tell you?
I
would say
I would
do the
say,
oxygen and
I think
then
I have
call
an
the doctor.
adjustment.
I
What?
think it notify the doctor.
I think O2.
Lane?
O2.
I mean,
I was
you could do
thinking notify
O2
MD.
and then MD.
Because
Identify MD?
because the patient has 2 liters of oxygen, right? That's like already the order in place.
Oh, I see what you
So
mean.
if we were to go over, I mean, we would have to get an order.
But you could do, you
Right.
could increase it and then let your doctor know because XYZ.
True.
Okay.
You can be like, I increased it because they have this and I'm scared of their
Yeah.
perfusion.
Let me check my notes, 'cause I could've swore there was something in
I
there about
remember
2.
saying
You can't be on like 2 liters, it's no more than 2 liters of oxygen.
No, they are.
It
They
makes
can get
sense
up to
do
3.
that and tell the
They can.
doctor after.
Well, because I feel like the doctor will be like, and what did you do about it?
Yeah, that's what I was
I feel like
thinking
it could be
too.
one of
I'd be
those
curious, go
situations.
look it up. Let me know what you think. Fine.
I say oxygen.
Manry, what's your thought?
I say oxygen because of the perfusion.
Yeah, I'm
as
thinking
well.
oxygen too.
Because if you could turn it up and then
Call it.
the doctor would be like, oh, okay.
What did you do?
Yeah.
Did you
what was
already?
the
I'm,
intervention?
you know what I'm thinking?
So let's
I'm
do a
thinking of
deeper
Mary.
dive. Let's do a deeper
What were
dive.
all the options
But what do
again?
you
So,
think the oxygen
How
would
often
be?
do we have PVCs? Everybody has them.
Premature,
Common.
premature.
Transient.
When does it become concerning?
If it's
But that's a
multiple.
lot
I mean,
in a
yeah.
row.
How
In a
many
I
row.
think
minutes?
so
A
is
lot in
like
a row.
You can have 6 a minute, right? And the bigger question is that the
Oh.
nurses know 8 PVCs in 1 minute, didn't say in a row.
Oh.
So there's 8 PVCs already in 1 minute versus like, so it's
8
like the norm is
PVC.
6, right? I know the norm is 6, I'm sorry.
So this is a normal, okay.
Well, then maybe notify the doctor.
What were all the options again besides like
Increase
the O2?
IV, increase O2,
Oh, yeah,
analgesic, and then notify MD.
oh, analgesic.
Maybe notify MD.
I know she mentioned something about 2 liters of oxygen.
And it was in part 1 or 2?
I don't remember, but I can't find it in my note, but I could've swore I heard her say something like that.
Notify MD.
Well, I
Well, the
can
doctor
say
should
in
know,
my-
right?
In my practice, I've never once ever said, don't give them more oxygen.
Oh.
So I don't know, I'd have to ask. I would have to ask her to see,
Yeah.
what did you say about this? And I'm like, I didn't say that, I said this. Whatever.
But I do
Mary,
believe
would you say something to me?
it is notify the doctor though, for sure.
Let me see.
Well, if it's like either like notifying or just oxygen only, then it's like I would notify the doctor out of those choices. But if I was out there, I would increase the oxygen and then I would tell the doctor. But for testing, I think it's notify doctor.
And that's the point, right? It's a matter of NCLEX, right? So do what they want to do. But I agree, everybody's like pretty much on the same page on this one. So, honestly, yes, the answer would be contact the physician, as for this, okay?
Okay.
So PVCs are often a precursor of life-threatening situations, including being attacked and being dead. So an occasional PVC is not considered dangerous, but if PVCs occur at a rate greater than 5 or 6 per minute in a post-MI patient, then the physician, the doctor should be
Oh,
notified.
post.
Yeah, so more than 6 PVCs per minute is considered serious and usually calls for decreasing irritability. administering medications such as lidocaine,
Okay.
right?
If post MI.
Most of the time, PVCs, again, unlike this guy has AMI, so I can't really speak to him, but most of the time, when people have PVCs, it could be caffeine, right? Or it's electrolytes. Electrolytes are also another common finding as well.
I had a situation second semester where I had like PVCs all day long. And it was, they ended up finding myocarditis, but I had like troponin in my blood.
Oh, I remember that.
Like
when he went
13,000.
Oh, that was you, right?
Yeah.
Were
But
you
I was
the
like-
one on PVC?
I was like fluttering, yeah.
You were the one on
Oh, shit.
PVC?
Mm-hmm.
You don't remember?
You
Jessica?
remember?
Yeah.
I
That
remember
was
you
like
guys.
semester, yeah.
Remember.
Yeah, I had to get everything done.
Oh, but you
I
had the
get-
PVC?
Did they figure out why?
It was myocarditis
Oh.
from either a virus or I like over.
Definitely has to be virus.
Yeah, they were
I
saying
think.
virus, yeah. I remember like I was running the day before and then the next morning I was drinking coffee and then it started
Oh.
and I'd let it go all day and then I finally went to the ER and they weren't seeing it on the EKG, but as soon as I got there, they stopped. But they had been going on all day long and then they decided to do a blood test and test for troponin and they saw how high it was. So
Yeah,
they fucking
it sounds like you had
threw me in
PSVT,
bed.
yeah. Paroxysmal, SVT, and it's just like AFib, same thing. And you can have ventricular too, PSVT. It's just like, it comes and goes.
Mhm.
It's like these people, this patient has these symptoms all day long, they come in here and say shit,
Yeah.
right? And then you put them on the bedside monitor, even though you do EKG, put them on the bedside monitor, and then an hour later, you're like, oh shit, there it is.
Mm.
You know, so, or sometimes.
As soon as they gave me metoprolol, though, it like stopped completely.
Are you still on it?
No.
That's the answer.
That's great.
Alright, cool. Alright, so,
Or gave you why?
some of the words that they use for these, I'm like, what the hell? What is some of the clinical, if a patient was in complete heart block, what's some of the assessment findings that you would anticipate? So your options are nausea and vertigo, flushing or slurred speech, cephalgia and blurred vision, syncope and slow heart ventricular rate.
Is this a saga?
No, this
Oh.
one's not.
Syncope. Slow heart rate? Oh, wait. Syncope and.
Can you say it? I'm sorry, can you say it?
Yeah.
So the patient has complete heart block.
That's third degree.
Blood's mostly, you're right, it's third degree heart block, right, is complete. Would most likely include nausea and vertigo, flushing and slurred speech, cephalgia and blurred vision, or syncope and slow ventricular rate.
I almost think it's the last one.
Yeah. Because they're.
This is where the ventricles and atrium is not talking to each other.
Yeah, like.
So there's no blood circulating.
There's no perfusion, or
Yeah.
not enough.
Not enough.
You would
I wanna have
see
it out. That's a
confusion,
I don't know if
I
they'll.
just really
It's
cannot
okay.
have them.
definitely pale,
I think that is
palpitation,
true.
syncope.
So
Yes,
that's- Which one, the third?
drastically
Yeah, it's third
low
heart block.
CO2.
So,
So
oh yeah,
syncope.
third.
There's
I
enough
think it's
thing
syncope.
to.
That's
Check it.
correct. Syncope and slow
it's the third
ventricular rate. So in complete AV block, the ventricles take over the pacemaker function of the heart, but at a very much slower rate than that of the SA node.
Isn't it like 40 to.
So there's a decreased cerebral circulation causing syncope, and patients with third degree heart blocks can have varying clinical
That's on the other
presentations.
side.
Rarely, patients are asymptomatic. Usually, they may present with general fatigue, tiredness, chest pain, shortness of breath, pre-syncope, and so forth.
You put this on your knees and elbows?
I normally just put it
Yeah,
on
so it's gonna be right.
Yeah, syncope.
You ever seen that lotion? Look like I'm pretty soft, but have you seen that lotion?
so, ready?
Yes.
So this next patient has a bundle branch block. So what should you expect to observe?
Isn't that the same thing as a,
Oh, bundle.
is it second degree?
So it's always in the QRS complex, right? Because there's no branch, bundle branch,
Oh,
right?
third degree.
So what signs and symptoms would you expect to observe in that patient? Like specifically on the strip, on the cardiac strip?
Their rate would be slow. Actually, it would be normal. Oh, no, regular. Just kidding. Reading is wrong. It'd be regular. Irregular.
Oh, she's girl.
I just shut up, Jazz.
This is all about heart failure.
Alright, so, your options again, right, for this bundle branch block, what would you expect? Would it be sagging ST jet segments, absence of P wave configurations,
No.
inverted T waves following each QRS complex, or widening of QRS complex to 0.12 second or greater?
I think it's the third one.
Third, inverted T waves.
No longer QRS.
Does it have normal P
If it's
waves?
P,
But the P waves and the QRS.
P waves are
not
still
related.
working. It's just the block.
Mm,
What an inverted T wave.
Oh, I'm sorry, can you repeat the question?
Sure. So if you had a patient that was had a bundle branch block
Mhm.
on the cardiac monitor, what are some of the things you would expect to observe on the cardiac?
You said no ST segment?
It's
A sagging ST segment,
QRS.
absence of a P wave, inverted T wave, or widening of QRS complex.
I kind of feel like the I kind of feel like it may be that first one, because it says that if it's the double, it would have normal P waves. And then you said something about the ST
Delay
wave?
on one side bundle block.
Oh, the
It's
ST
the
wave.
wider QRS complex.
Oh, bing, 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 there we go, yay, you did it. Widening QRS complex, right.
I wrote it down.
What slide is that under?
Good job.
Slide 8, right?
Under, she talks about it right after the normal sinus rhythm.
Oh,
Oh.
The bundle branch block interferes with
Tell me what
conduction
slide
of
that
pulses
is.
from AV to its ventricle. Supplied by the
Double
ventricle.
check against yourself. Yeah. What did you say? Those wider-
Conduction to the ventricles is delayed by, as evidenced by a widening QRS complex, the second main read said. Rhythm must be
So slide
of
37.
SBT origin, though, which is interesting. Good job.
What slide is that, man? Like,
What's the title of the slide?
do you know the
It's
number?
The title.
What's the title of it?
Normal sinus rhythm,
Oh, no.
right after that.
Oh,
after
I didn't
But
know
like,
that.
it wasn't on the slide, you had to type it out. Like,
Yeah.
where is that?
Didn't
The one with
catch-
the heart.
It would be on slide 36.
36,
This
thank
one.
you.
Yeah.
Slide 36.
But yeah, I wouldn't have known that one. Oh, thank you. Yeah, definitely.
That's why I pays to write notes.
It does. Good catch.
She's on in my notes. Like,
All right, so this is a silly question,
Mm.
but let's pretend you're working in the ICU or in the cardiac ICU, and your patient all of a sudden goes into VFib. The first person reaching the client should do what? Administer oxygen, defibrillate the client, initiate CPR, or administer sodium bicarbonate intravenously.
CPR.
Initiate CPR.
No?
Because of where we're at.
Defibrillator.
Oh, the
Patient
right
that-
away?
Yeah,
Oh.
early defibrillation is the key. Yeah, it's a little
Early
tricky. You know, if you're on a med surg floor, it'd be a different story, because then you don't even know, you wouldn't know. Then you're gonna tell them. The other thing is too, like a little red herring, because it doesn't say whether or not the patient's conscious or not. See? You're like, damn it!
I don't know, I'm just like guessing myself for this damn so.
Well, that messed me up in the first exam.
Oh my god, you're gonna be cussing me out when we do endocrine. It's like, this is hard.
Can we do this again? We're not there yet, but I'm
No, don't even worry about that. Yeah,
I'm
exactly.
stressed out.
That's why it's 2 classes. I'm like, one day is gonna be kind of a breeze. The other class on Friday, and that'll be more, smooth rolling. Okay, so for question 15, what criteria should the nurse use to determine normal sinus rhythm for a client on a cardiac monitor? So in other words, how do we know? How can we tell if a person's in sinus rhythm?
Normal sinus rhythm?
So your options are the R to R intervals are relatively consistent.
Consistent
Yes.
R2R.
1 peak wave precedes each QRS complex.
Mm-hmm.
4 to 8 complexes occur in a 6-second strip. The ST segment is higher than the PR interval.
No.
And then the QRS complex ranges from 0.12 to 0.20 seconds.
Yeah, that's it.
I
So
think
it is a static, so.
the first two are the last. I think it's all of them except for that
ST?
third one.
ST.
That ST one.
Okay, so the S to the R intervals are relatively consistent.
Yes.
1 P wave precedes each QRS complex.
Yes.
4 to 8 complexes occur in a 6-second strip. The ST segment is higher than the PR interval.
Wait, 1, 2, 3.
ST. No.
So the 4 to 8 complexes occur in a 6-second strip. The ST segment is higher than the PR interval. Or the QRS complex ranges from 0.12 to 0.20 seconds.
Oh, the ST wave is supposed to be higher than the PR interval? No, it's supposed to be low, because that's the way the thing says.
I think
Last
it's
one,
the PR, isn't that be to the top of the?
The ST segment is higher than the PR interval.
No, that's
No.
not that one.
That would be
QRST, yeah.
I think the R to R should be consistent.
It should be higher, no? Because this
Oh,
is Q,
yeah.
this is P, R, P, Q, R, S, T.
PR, that doesn't sound right.
Yeah.
Yeah, Q,
So meaning it's wider, right? How wide to measuring,
oh, I see.
right?
P,
So
30 boxes, 6 seconds straight.
T, S, T.
I think it's the first, second, and what was the last one?
QRS,
the last one is
0.12.
the QRS complex ranges from 0.12 to 0.20 seconds.
Oh, yeah.
Oh yeah, wow.
Oh,
That's correct.
yeah, that one, actually, no, it's not the last
QRS.
one, because the QRS should only be
0.06
0.06 to 0.12 seconds. So I think it's one of the first two.
Okay, I think it's just the first 2.
I'm not gonna lie to you, I don't remember the rest of the answers.
Alright, so 4 to 8 complexes occur in a 6-second strip, yes or no?
Oh,
That's
48.
40
4
to
to
80.
4 to 8.
No.
Yeah,
6-second strip.
that's 40
60
to,
to 100,
Yeah.
they're normal.
So
Right?
yeah.
Yeah, that's
your
right.
examples are all 6-second strips.
Yeah.
You have a
But it shouldn't be 4 to 8, because then if it's only 4, that
That's
means
the
that
only
bradycardia,
no.
it has to be 6 to 10. Because remember, it's 6. You think so? I thought a normal heart rate doesn't go from
6 to 10.
60 to 100, so it would have to be 6 QRS complexes.
6 to 10.
Wait, is it just normal sinus rhythm without bradycardia or tachycardia?
It's normal sinus rhythm.
Oh,
I don't think
okay.
it could be,
The question says normal sinus rhythm on a cardiac monitor.
I don't think it could be below 60, and then that would be bradycardia.
It has to be at least 60.
It has to be at least 6.
Maybe I'm getting confused, but I thought it was a 6-second strip. And right here I'm counting 1, 2, 3, 4, 5, 6 in 1. Isn't that between 4 and 8?
Yes.
You know,
Wow, that's a good point. All right, then, the ST segment is higher than the PRR interval, yes or no?
no. ST wave shouldn't be
No.
higher.
So what's an ST, what's a normal rate for ST? So remember, it's QRS, right? And then the S to the T.
So 0.44 seconds. What's QT? Sorry.
Oh,
Mhm.
hello. ST should
ST is the
be.
relaxation
Yeah,
phase.
it's repolarization, right? So is the ST segment higher than the PR interval? And is that
No.
normal?
No.
No,
Right,
because
okay.
it's
So I
relaxation.
think you found your red herring here.
Yeah.
The QRS complex ranges from 0.12 to 0.2 seconds.
No,
No.
because it should be 0.06 to 0.12 seconds.
Gotcha, okay. All right, well, for those of you who said you think it's just the first two, you're correct. It was just the first two. The R-to-R interval is relatively consistent, and one P wave precedes each QRS complex. The consistency of the R-to-R interval indicates the regular rhythm. A normal P wave before each complex indicates obviously that the patient's in sinus rhythm. Sinus arrhythmia is most typically present in young, healthy individuals. Studies have attempted to establish increased prevalence of. What the fuck has that got to do with anything? Yeah. Anyway, I'll go into like option C here. It's like the number of complexes in a 6-second strip is multiplied by 10 to approximate the heart rate. So normal sinus rhythm is 60 to 100. And the EKG sinus rhythm appears as a beat to beat variation.
How many QRS complex there is in the strip?
So I think
You
it's
could multiply, if there's at least 6, then you times that by 10. So if there's only 4, and you times that by 10, that would be only 40 beats per minute.
Right. And these are the patients in
Yeah.
sinus rhythm. They didn't say sinus breathing.
Yeah.
So that was a little bit
Oh,
below.
found it. Okay. I was just trying to
But I
look
get what you were saying,
under
because
French,
the
so
6
thank
is
you.
in between the 4 and the 8.
yeah.
But 6 has to be the very bare minimum.
Good job. So hey, we're listening into the chest for the apical pulse. On a patient who has AFib, the nurse would expect to hear a rhythm that is characterized by what? The presence of occasional coupled beats, long pauses in an otherwise regular rhythm, a continuous and totally unpredictable irregularity, slow but strong and regular beats.
Is
I think so.
irregular the regular?
The third one.
Can you say the question one more time, please?
When auscultating the apical pulse of a client who has AFib, the nurse would expect to hear a rhythm that is characterized by what? The presence of occasional coupled beats, or long pauses in an otherwise regular rhythm, or a continuous and totally unpredictable irregularity,
I think it's that
or
one. Yeah.
slow but strong and regular beats.
The
Third one.
Correct, the answer is C.
Mhm.
It's a continuous and totally unpredictable irregularity. Good with that one?
Yes.
Yes.
Thank you.
Awesome.
Okay. Atherosclerosis impedes coronary blood flow by which of the following mechanisms? How does it impede it? By plaques obstructing the vein,
Mm-hmm.
plaques obstructing the artery,
Yes.
We actually read it. We read it.
blood clots form outside the vessel wall,
There you go. There you
or
go.
hardened vessels dilate to allow blood to flow through.
There we go again, now reading the
Can you say
question.
that? Pardon, what was that?
Atherosclerosis,
Mhm.
an The answer is in the question. Impedes coronary blood by flow
Impedes.
by which of the following mechanisms?
Coronary flow.
Coronary.
Plaques obstruct the vein,
The,
plaques obstruct the artery, blood clots from outside the vessel wall, or hardened vessels dilate to allow blood to flow through.
Okay.
I guess,
The answer is in the question.
Artery.
artery, yeah.
Don't second guess.
What does the first word atherosclerosis?
It's the artery.
There we go, there's the trick.
Arterial.
It's the artery.
Dig the damn question. No.
Atherosclerosis, always think of artery.
There we go again.
Coronary arteries, you know, so.
So,
Okay, paradoxical pulse occurs in a client who had a coronary artery bypass graft. You guys talk about cabbages?
Cabbages.
Cavities,
Cabbages.
Cabbages.
Oh,
Wait.
Coronary
cabbage?
artery bypass graft, did you talk
Oh,
about
yes.
cabbages? You may have learned about this in second or third.
we talked
A
about graft.
cabbage?
No graft.
But why does it sound very-
I remember a cabbage.
I don't remember any cabbages.
It's narrowing.
I know they say sometimes you could put a cabbage on your like
On your teeth.
that's like an old. Wait,
Just,
okay.
just research it.
So if the patient had an occluded coronary artery, which of the following surgical complications should the nurse expect? What would you expect? Like, if somebody had it, regardless of whether they had surgery or not, if there was a coronary artery blockage, right? What complications would you expect for that patient? A left-sided heart failure, aortic regurgitation, complete heart block, or pericardial tamponade.
The left heart block.
Paradoxical pulse is an interesting thing.
Maybe one? Maybe the
It's
first
A,
one?
the left.
Maybe the first one, the left heart?
Yeah, so if you ever see it, it's not, but if you ever see it, it's in the boards.
Uh-huh.
Always,
Makes
it's much like how the, like this told you about arterial, but atherosclerosis, think of arterial, A.
Uh-huh.
So for this one, if you ever see it, and we'll talk a little bit about this with chest tubes too, it's a paradoxical pulse.
It's
It's
the
the
left.
pericardial tamponade. So what it
Oh, she
does-
mentioned something about the cardiac tamponade.
Yeah, so we have to do a window and they vent it. So a paradoxical pulse is a palpable decrease in pulse amplitude on quiet inspiration. So if, like, you had a patient hold their breath or slowly breathe, or slow down the work of breathing, you can actually have a pulse deficit. It will slow down.
Wow.
So, anyway, it's a common, not a common thing, but it can be a complication of bypass surgery. Cabbage. The cardiac tamponade is a medical or traumatic emergency that happens when enough fluid accumulates in the pericardial sac. I talk about this in our ER discussion. I don't see it that often,
So it's
but.
cardiac.
So the answer is a cardiac
Yeah,
tamponade.
so patients who have cabbages,
Mm-hmm.
maybe they get discharged to the home, they're at home, and then they show up in the ER with chest pain in the middle of the night. And sure enough, they, every once in a while, we discover this.
Oh, wow.
I still don't understand the cabbages part, I'm sorry.
So no cabbages.
It's a coronary artery bypass graft.
The cabbage.
So what they're doing is they're opening up the coronary artery, and put stents in there, cabbage, cardiac stenting, cath lab.
I think she's still not understanding it.
Wait, so is the cabbage, is that like the
Yeah, she
coronary
did.
artery bypass? That's
The
like
coronary artery, right, is blocked, and the nickname is cabbage.
Oh.
Coronary artery, it's not.
Are you talking, are you thinking about the cabbage, girl?
I was just like,
It's an
when does it
acronym.
come back in?
Coronary
I ain't gonna lie,
artery
I thought it
bypass
was
graft.
I'm just kidding.
I'm sorry, I kept thinking of cabbage, like, what is it, what does it have to do
It's
with
an
it?
acronym.
You okay?
I'm sorry.
You got it.
It's
It's okay.
good.
We're
No,
all
yeah. I was envisioning it too though.
I'm gonna say
I ain't gonna lie,
I'm gonna listen to like
Yeah.
this stuff now. I'm gonna re-listen.
I was thinking about some Filipino shit, just putting the cabbage on it.
Did you guys learn about MAPS, MAPs?
Yes,
Yes.
yes, definitely. She went over that a
Did
lot.
you do some practice?
Yeah.
That one?
Sure.
All right, ready? So after cardiac surgery, client's blood pressure measures 126/80. The nurse determines that the mean arterial pressure, the MAP, is which of the following? I'll let you do the math. Remember how to do it?
Something about cardiac plus something divided.
Systolic times 2 times diastolic
So you got a
divided by
math
3.
problem.
Right?
We divide something with something.
I thought you just subtracted.
Hold off on ordering until officers can discuss
Wait,
our
I'm
ordering
just gonna-
options and budget. Sorry, just got the.
That's what Becky said.
That's what Becky said. So don't order, guys. Map.
Here, we're in here, let's talk about math.
Oh my goodness.
He has the math here. Math.
Don't say it. Don't
We
forget.
talked about it in the first part of it.
Yeah.
All right, PEMDAS, guys. PEMDAS.
Here's the math. Let's see the
You want me
second.
to give you a clue?
Wait, I'm doing
I'm gonna find
PEMDAS.
it, I wrote it down.
No, I mean, you want me to give you like the algorithm or you?
Oh,
yes,
Nine-
okay.
the algorithm, yeah.
Okay.
I don't know if I did PEMDAS right.
No, it's all right, I want to answer.
Is this
you.
a
I wanna see-
is this a DD?
Thank you for your answer.
Kind of.
I will get back to you. I will get
Okay.
I will respond with the answers once everyone's done.
Okay, so
Because I really want you to figure this out.
no problem. 3.
Do you need to know what the acronym is, or like how to figure out the MAP?
The formula, what is
Okay,
it?
so it's 2 times the diastolic pressure,
Times diastolic pressure,
2 times the diastolic pressure plus the systolic, divided by 3.
plus systolic divided by 3.
It's 93.
It was 160 over 80, right?
126 over 80.
I thought it was 120 over 80.
No, it's 126
Oh,
over 80.
126. Oh, oops.
Where did I get 60?
That's your memory.
Plus 126.
Times
46.
Oh, then it's 95.
46. Wait, did I do that right? Oh no.
You're so funny.
Pizza cat.
283 divided by 3.
Okay, so that's 46.
That's part of the song one. Like, oh no, my.
So 80 plus 46
So 85.
P.
What did you get?
Does it have to do with Western? No, because she said, oh no, it's part of the thing. Like, oh no.
Divided by 3? What was the thing? I'm sorry.
2 times diastolic plus the systolic divided by 3.
Was it 95?
2 times?
2
Okay.
times diastolic
2 times diastolic.
95.3, but you
plus
round.
systolic
Three,
divided
so
by
it's
3.
below the point
So I'm
5, so you
thinking
got
80 plus 80 is
So you gotta
160.
go round down.
Plus 126 is going to be 283, right? Divided by 3.
26 plus
Okay.
80
So that's going to be
times
85.
2 divided by 3.
This is a good DDC question.
God, I
Did
hate
you
that.
get 85? 95?
I got 95, but I don't know if I did the math
How did you get
right.
95?
Yeah, it's 95.
It's 286.
It's
Yeah, 286.
286. Yeah.
286 divided by 3.
Yeah, so 95.
Mm-hmm. I
It's
verified.
20
with
divided by
my
3 is
calculator.
27.
I verified with my
And
calculator
that's
too.
16.
Still commit to
Because
that.
it's what? 80 plus, times 2, that's 160, plus 126,
Oh,
it's going to be 280.
times. Okay.
Times.
See, I can't do PEMDAS.
Times.
And I know what you're
Super
doing.
generic.
So that's
Oh, I did?
95?
Michaela, don't
Really?
second guess
Never mind.
yourself.
No, I was doing a different formula than you guys. I didn't know if it was the right one.
Oh no, you got it right. See? 286 divided
Oh,
by
it is
3.
95.
You had it.
Okay.
How was the
You have it. Oh yeah, it is 9. Because
Okay.
9 is 27. So 95, yeah.
PEMDAS.
All right, good job. 95 is the answer, right?
You got it right.
Okay.
You should have come up with 95.3.
I know.
Yeah. Okay.
All right, good job, you guys.
Just remember that formula. And I really thought that we needed to know it too.
Did she talk about that
She did. She went over it
Yeah.
quite a bit.
in the beginning?
I think it's the second part of the lecture.
Okay.
The second part.
Okay.
For the
I need
map.
to go through that. Oh.
It's in shock.
Oh, it's in
That's
shock.
probably the most important part.
Yeah, I know one of them
It
said
is,
something
right, it is
about
in
that.
The reason for that is honestly when they write, like when you have to put a patient with a
yes.
pressor,
Yeah.
the physician will write for MAP to be greater than or less than, right?
Yeah.
If a person had a hemorrhagic stroke, right, and they're bleeding,
Yes.
right? We want to lower that blood pressure, right? So the doctors will write, like to give, to lower that blood pressure down. And they'll give, they'll usually use MAP or it'll be systolic BP less than, right? Conversely, if it's a shock situation and you have to convert to a depressor, because remember you do fluids first and that doesn't work, then you go into depressors, right? So then it's based upon the MAP. And they'll say goal of like MAP greater than 60, you know, or something like that.
That's usually the base, right? Greater than
Usually it's 60, yeah. Well, oftentimes they'll write, like, well, I shouldn't say oftentimes, usually 60, but sometimes you'll see 40 to 60. So, and like a pediatric patient usually,
Oh.
it's a little bit different.
Did you like your peds rotation?
Did I like my peds rotation? I love my peds rotation. I get sick every effing time. I'm serious. It was like, cause I wasn't around kids and I didn't have kids, you
Yeah.
know. So, but every time we were there, but we did 12-hour shifts,
Yeah.
Oh.
2 days in a row, and
Oh,
we did every weekend. We did Saturday,
That's
Sunday.
crucial.
Yeah.
I mean, we kind of, I mean, when we were
We
there,
did
she
one.
had
We
us,
did one.
that's right, one day.
One
Oh
day.
yeah, it would have been brutal if it was 2
It was
days.
2 days.
I ain't gonna lie. I
We
be
weren't
feeling
used to it.
sick.
It was crazy. Like,
Yeah,
I would
that-
go there,
No, the
you know,
brutal
Saturday
part was
morning, be
getting up
fine.
early.
By Sunday afternoon, I'm like, like sick as shit.
You got like a new
Like,
disease.
yeah, I was like, God damn it. But I'm like, yeah, well, honey, sick as, you know. Working in ER nurses are like that. They have
Same
like
thing.
brand new grads out of nursing school.
Yeah.
Every time they get sick as shit. And I'm like, "God damn it."
54%.
Looks like that's
See, the thing about ER is you have to remember most diagnoses, people aren't diagnosed before they go to the floor. You have to diagnose them.
Yeah.
So then we'll get letters 3 days later. Oh, by the way, patient had TB, right?
That's
Doesn't
true.
say-
That's true.
Yeah,
Right.
that's true.
But you just be wise and you know, you just see shit and you're like, this is probably, I'm gonna wear, my spidey instincts are telling me to put a mask on. So I'm like, you know, that's the reason, that's why I'm glad the county finally got their head out of the sand here. And gave it back to like using nursing judgment with the mask thing.
Yeah.
This is ridiculous. So I was like, oh my God, seriously. So we have to wear them here in a patient room, right? Well, you know, you guys are
Yeah.
supposed to too.
Yeah.
But, you know, but honestly, it's just like, and most of us don't.
I would wear it.
Most of us don't
I know,
do
like,
that
you
because
don't-
like
you don't know
most
what
people
you're gonna
like,
get.
don't have a
Yeah.
respiratory problem.
You know what they
They're
have.
like there for other reasons, right? It's like, okay, well, yeah, sure. You know, it's not like I'm camping out in your room.
But it's better safe than sorry.
It's just no, but you use your judgment.
Yeah.
I can tell you that like almost 3 years of COVID, I never got COVID from here. I got COVID from my husband coming home to me, bringing it home to me from his fucking office. So,
That damn office job, no.
well, I mean, like it's like a really old building, and like they have like 6 offices in this tiny little space. Even they're like kind of separated by like these fake walls.
Cubicles, yeah.
And it's just like he's just like, wow, man, my boss just keeps coughing. I'm like, you better probably should. Are you wearing a mask? Well, we're not next to each other. Like, Dill, are you wearing a mask?
Yeah,
Express,
You know,
express.
Sure enough, I was like, son of a yeah.
What about your L&D? Did you like that?
L&D, not really. I did not enjoy L&D at all.
Okay, that's fair.
And then when I did my assessments, I did them from the doorway. Hey, how's it going? Everything going? But yeah. Okay, good. Thank you. I
Yeah.
never touched a woman. I'm serious. I never went in and listened. Not one time. I did it from the doorway. I'm not gonna lie. I'm not gonna
Feel
lie.
good?
That's
Yeah,
funny.
that's it. And honestly, like, and my preceptor was like, she was like pregnant herself, and all she ever did was she sat down at the end of the hallway all the time, and her pregnant self.
She's
just
in the
sat
best
there
place.
the whole
She
time,
was
like
in the best
whatever. Like
place.
I never went in to go, and I was just like, well, yeah, it's like, well, if they question me, I'll be honest. I'm not gonna lie.
But they never
yeah.
did.
I hated that post-op crap. But
Yeah.
but I was the lucky one. I had 2 vaginal deliveries. I had 2 C-sections.
You were in
Oh,
the
yeah.
corner for that, away from the splashdown? Or
Oh hell no, I was right there. I was
They
like,
actually
yeah,
let you?
I want to see that shit. Yeah, yeah. I'm not sick bastard. Yeah, I want to see it. Yeah,
Fair.
yeah, it's crazy. Yeah, I was like, then I had classmates that didn't even have any experience whatsoever.
Yeah.
Like, like, oh, why did anything go wrong? Like that crap. It was like
Yeah.
common, but I don't know. I was like the baby whisperer or something. Even my instructor was like, "You're so fucking lucky."
Oh.
Yeah, I was like,
Who was it? Who was it? Sam?
Pima.
Pima had like, how many in one rotation? Like
Like 3 or
3?
4.
4?
Wow.
That was insane.
Sarah was like.
And she went to the OR too.
yeah, that part was cool.
Yes.
The mother baby was boring.
Yeah.
Oh,
That is
postpartum?
Wait,
postpartum,
I
yeah.
hated postpartum.
I couldn't
I
stand
had
it.
7.
I never did
Kathy
anything.
pulled me off early because I was like, I don't like this. And she's like, well, let's take you back over to L&D.
Like, that sounds good.
Yeah, I was like, get me
Yeah.
off this floor. Postpartum?
Ugh.
It's so freaking boring.
Was that the same day you and Lai helped that one pregnant lady? No, that was different.
Karen had that one crazy lady in postpartum.
Yeah,
The one that was on
cried
drugs.
for.
Yeah.
What?
Yeah, she was on drugs.
Oh,
Karen
that's
had her. Karen had to tell her, like, can you stop running up and down the halls?
Oh, that lady.
Yeah.
Just giving birth to.
That lady.
And Karen was like, give me your baby while you take a shower. Like, we will have your baby over here.
Oh my god.
That's horrible.
Karen always gets the crazy ones.
And she gets all this
She
experience.
feels so bad. She stay getting the crazy ones during political. Oh, we missed it.
All right, ready for one more?
Yes.
Yes.
This is the last one on this. A woman with severe mitral stenosis and mitral regurgitation has a pulmonary artery catheter inserted. The physician orders pulmonary artery pressure monitoring, including pulmonary capillary wedge pressures. The purpose of this is to help assess for what? Degree of coronary artery stenosis, peripheral arterial pressure, pressure from fluid within the left ventricle, or oxygen and carbon dioxide concentration in the blood.
Easy to B or D, one of them. I can't remember what the question was. But B and D sounded right. B and
Was
D,
it a
one of
soda?
those.
What's
No,
that?
it's not a
It's not a
soda.
soda.
It's not a soda, it's just one. It's one.
Can you repeat the question? I'm sorry.
Sure. Let me try to summarize. Patient has mitral stenosis
Okay.
and also mitral regurgitation.
Okay.
So they decided to put a pulmonary artery catheter in. So, what does the pulmonary artery catheter do?
Oh,
What does
okay.
it measure?
Okay.
Also known as wedge. It's doing wedge pressures ultimately, but what does that mean? So, is it degree of coronary artery stenosis, measuring the peripheral arterial pressure, measuring the pressure from fluid within the left ventricle, or measuring the oxygen and carbon dioxide concentration in the blood?
The pressure.
I think it might be beer.
Thinking it's B.
Peripheral arterial. No.
I thought it was B though.
I feel like that's a red herring.
I think it might be C because
I
it
felt
says
like the
mitral.
ventricle.
Yeah, mitral stenosis is on the
Fluid
left side.
in the left ventricle.
Yeah, so I think it might be C.
Stick with your answer. Stick with your answer.
B.
If you think it's
Peripheral
what it is, stick
arterial
with it.
pressure?
It's pressure from fluid within the left ventricle.
Okay.
Correct. It's C.
See?
Yep, you're right. The pulmonary artery pressures are used to assess the heart's ability to receive and pump blood.
Fluid in
Also,
the left
the capillary
ventricle.
wedge pressure reflects the left ventricular and diastolic pressure and guides the physician in determining fluid management for the client.
Yeah, because mitral stenosis and
Alright.
regurgitation.
The next Dr. Limbaum coming through.
Hell yeah.
Be rolling in dough. No, I'm just kidding. I'm just kidding.
One of her students told me, like, one of her students told me the other day, we were only there like an hour, and she's like, we all had to go. I have a cat to go.
We had to go. Have a cat.
They must have loved that.
Crazy.
I'm like, all right,
She's
well."
on call?
Yeah, she was on call.
Oh.
Wow.
I need.
Priorities.
I mean,
Get it, girl.
Worked out for Crystal probably.
oh, that's what she.
She's
She
cool.
had that great patient and she had to leave. That's what he said.
Oh.
No, you're like, she has to go home and pick up her kids.
Oh, so
No, 'cause
she's
she was
like
saying that
in the
day she
field,
had like
huh?
a great patient.
What happened?
Crystal was telling us she had a great patient. It was a retired CRNA.
Oh,
And she was like
wow.
talking to him and all these things,
Uh-huh.
but then she had to leave. But that makes sense because she had to leave because of that.
Aw,
Um,
dang.
She's like, he was great.
he was like quizzing her, right?
Yeah.
Telling her,
Wow. Wow, that's cool.
Dang, Dr. Limbaum, she's like
She has
hero.
some business.
She's like Wonder Woman.
Get her a Wonder Woman sticker.
I love Dr. Limbaum. This is cool.
Mhm.
Her voice is so relaxing.
Yeah, and she's so smart.
Who, Dr. Rumbob?
Yeah.
Oh, yeah.
Even though she gives you way too much information.
Oh, yeah.
So there's like,
She
oh,
be
don't-
talking hella
don't
fast, but it's
forget
it's
about that.
relaxing.
I never fall asleep on
Yeah.
lectures.
The pacemaker
Never.
notes that I've made
Yeah.
cover the whole
Sometimes
page.
she
I
just-
believe you.
She's just so like really. I don't know. She just got that voice. That she's like,
Her voice is
Totally loves all the cardiac stuff in
Yeah.
particular.
yeah.
And obviously that's her world, you know.
Mhm.
I mean, I love it too. And it kind of bummed me out. I'm like, oh, I don't get to do it.
Aw.
Well, we all have our favorite subjects, and like cardiac's mine.
She sounds like an angel. Like the angel the harps are playing. No, seriously, she is. She's like a walking encyclopedia.
Well, I tell you, like endocrine and fluid electrolytes. I do fluid electrolytes first semester,
Mhm.
Yeah, that.
and it's boring. It's like, and so is endocrine. It's boring, and but it's like, how can I take this really horrible stuff and try to make it interesting? So that's why, like, if you watch the full video that I made, if you wanted some sleep there, get some sleep.
Drink
You
some
can
coffee
tell,
before you listen
You
to a
can tell when I'm
lecture.
really interested when I'm not. Just FYI. You can tell by my videos, in my certain videos. There's parts of it that I really like, and then there's other parts I'm like, oh my god, this is just so insane.
Is it hormone heavy? Or more pathophysio?
If you look at, there's no reason why you should have seen any of this stuff already, but like if you open up on the very first page, the intro.
I'm so sorry, I don't think I even touched that.
Yeah.
No, you shouldn't have.
But
because
you have
it's
three
not-
PowerPoints on there. I saw. And then there's recordings, pre-recorded lectures.
That's correct.
Yeah, I just
the-
haven't touched it
There's
yet,
a
that's the
really
thing.
long,
Because we're still
the
focusing
first
on
one
the exam.
is a combination of everything, and it's really long.
Oh.
And there's a lot of information. So then what I do is I take smaller portions and make 10-minute videos or less.
Oh,
Of what,
Oh.
in other words, this is what you need to know.
Okay.
Right?
Okay.
Kind of thing.
okay.
So it's kind of like, because it's like,
So do we have to listen to the pre-recorded
you can
because
do
it's
whatever,
HyFlex?
whatever you feel you need to do. I'm just saying it's like, but I will tell you this, that you open up the book and you open up the PowerPoint and it will be page by page. And you'll hear me talk through the whole thing.
Oh.
There's so
So you won't miss anything.
Okay.
So I'm
What's
just saying,
what's your
but it's
recommendation?
really long.
What do you believe your recommendation is? Because I'm gonna follow it.
I think it's whatever your
For-
learning
for
style
that,
is.
as far as I'm concerned, that the bottom line is, I feel that you really should watch everything, but I think the
okay.
bottom line is like, that's why I made the smaller versions of this, of the videos. Because it's a lot of
She
information.
said, weird.
If you open up the very first endocrine module overview, and you talk about like key concepts and stuff, and if you go down
That's scary.
to like hormones of the endocrine system, like I put a little thing here, and you open the click on that. This kind of summarizes a lot of stuff
Okay.
that you would want to know.
That's what I'm looking for.
And then I embed it also.
I'm gonna see about going to that EMT class on Wednesday next week. I gotta email him about that. For the EMT.
On the study
training
guide.
For
The study guide,
thing on.
it's just a,
You know how you go to the.
down towards the bottom.
See, you're fine.
Outline.
I get
the voicemail from the dad.
Description of hormones.
Oh,
So on the study guide portion, right, in the second part of that thing, if you scroll down all the way at the bottom, see there's like a description of hormones.
Right, study guide.
Oh, yeah.
So it says like a growth hormone, it's excreted by the anterior pituitary. If there's not enough being produced, then it's a growth hormone deficiency. And overproduction is acromegaly. So you literally can make flashcards out
But
of
this is
this.
why I still have to listen to
We
Anderson.
You can
not
just-
learn about the
But you know what?
diabetes
This is just for the
insipidus.
cardio.
No, because that was
You'll learn
last.
about the eye.
In this one though?
Correct. You will.
Oh, okay.
Mhm.
Red Belt, she's gonna use
Yep.
I
this
feel like we
Because
have
I
not
looked-
touched
I
on
looked-
that.
Yeah, you'll
One of the
learn
questions in the
the
she said,
combination
what
of
would you do
DI
this and
and
that? Like, if
then
like, for like
SAADH
home
as well. That's really
recommendations,
important.
we look on like
The
hygiene that
serum
like,
inappropriate
like
antidiuretic
washing your
hormone
hands.
is opposite
And that was
of
one of
DI.
them, like the guy's electricity, the water
The DI
is down
insipidus
like
is just a
this.
matter of like,
I fucking highlighted that shit.
Oh, so that's what the T3,
is
T4
is that you'll just pee it out, thirsty pee it, that's DI. Whereas SIADH, you don't have the antidiuretic hormone. So,
You're like retaining it,
you
right?
retain, it's the opposite, yeah, where you're just retaining it, yeah. I mean, see, even myself, it's a complicated
confusing.
subject.
Wait, antidiuretic hormone, you don't have it, so you
Serum
pee?
inappropriate antidiuretic hormone. So, it's
I think
like,
it's-
it's
there's an
it's the other
overproduction.
overproduction.
Serum
Then you
inappropriate
retain.
antidiuretic.
Pretty much, yeah. You'll understand, you'll see.
I'm
Yeah.
actually kind of excited.
It's a cool thing, it's kind of neat, it's hard.
Diuretic
How come
could
this
be
is
used
so
for
hard?
anti, you
So
don't. It's
antidiuretic hormone, we
But
still
people
have to have it,
fucking know.
Yes.
because it's a mechanism to keep it
sorry.
balanced.
Yes.
So it also actually pulls into the renin-angiotensin system, you'll see how it connects. And what happens is that some people don't have that ability.
Oh, so they just
So
pee.
they'll just pee, and pee, and pee, and pee, and pee. Yeah.
Dang,
During
that's
this
not good.
Mhm.
That's not bueno.
And my friend had that question.
Diabetes insipidus is the same thing.
You gotta figure out that shit, guys.
But does it do
So I'm
anything to
gonna
your blood
repeat my
sugar?
questions
yeah.
with all this shit. It's all over
He's a
the place
dentist,
this semester.
right?
It's just too much. But I'm gonna go back and
But it's next one to gone.
on the
Do
10
they
millimeters.
do
Yeah.
I swear she talked about that shit like
No,
5 times.
no.
Yeah,
not
all the
DI.
time. 10
No,
millimeters,
it's,
guys.
Always have to
it's
be 10.
actually,
It always had to be 10.
Are you going to the bathroom?
it's a cool
Yeah.
nice.
Oh, really?
Held off for
Yeah.
this long, yeah.
I kind
I
of
didn't
get
use the
off the top
bathroom.
of my head right now, but it's just like, see, I have to review it again, I'm like, wait.
Yeah, I'm gonna-
Because it's not like
I
easy
even
to
printed another one,
memorize.
so I can listen to it and rewrite my notes.
Yeah. I think one thing I don't like about
I have to read
the endocrine stuff is like
Hopefully I understand it.
that's the hyperkalemia and all that stuff,
I
right?
found this
Part,
quick
Kind
not
of.
really, it's more
and from this
fluctuating.
one,
Oh, I
and
don't
that's a
like the
lot of
electrolyte
questions, and it even
stuff.
highlights the things you gotta write down.
To
I
remember
didn't
like
look
what
that,
this,
so-
all that stuff was.
The labs,
Yeah. Or just-
cholemia, I'm not
What
gonna
are
lie,
the
I don't
signs
even
and
remember
symptoms?
a lot of
I
them.
remember first semester that was like the
The
worst.
main-
for
Yeah,
me.
I made it easier now, like, and now that I teach it, it's a lot easier.
It was
Who,
so
who
hard.
taught it?
I don't remember.
Probably Michelle or,
It was so difficult for me to like understand that.
I think I let that section,
I remember just reading it over and over and over, and I was writing it down, and I just could not get it.
I couldn't get it either.
Yeah.
I let that one up to God, honestly.
I
That
feel like the
whole,
whole first semester was
Yeah,
up to
there you go.
God.
so if it was underproduction.
I don't know what I'm doing.
Antidiuretic hormone, if it's underproduced, right, that's where the
retention?
it's excreted from the posterior pituitary.
Oh.
And so if it's underproduction, then it creates this diabetes insipidus.
Oh,
Whereas overproduction is too much, is serum inappropriate antidiuretic hormone. So it's very interesting how it kind of works. Yeah.
So diabetes insipidus, is that something that like people will be stuck with, or can they get rid of it?
It's correctable.
Is
Yeah,
it?
yeah. All these things are pretty much correctable. It's just a matter of like having the right med. And sometimes
'cause it's all
surgery.
hormone based, right?
Mm-hmm. Yeah, Addison's disease, Cushing's disease, there's cortisol interferences.
So how do you deal with the cortisol then? Is there medicine for that?
Yeah, we took
Yeah.
tests.
And then, yeah, and then not only the cortisol itself, but it's just like you can, I forget what else cortisol affects. Like, it's a matter of like,
It's like a stress
every
hormone.
hormone, hormones are either excreted from a gland or an organ, and then what's excreted affects another organ, and so forth and so forth, right? And so on. So if there's not enough of it, then it's going to affect the production of the next thing it goes to, right? So it's kind of like this triad. It's crazy how it ties in. It's very fascinating stuff. But to be honest with you, there's really not a lot of questions that you have in on NCLEX, because the biggest one is diabetes. And that's obviously the most important thing, right? But you learn about diabetes in first, and then second or third semester whenever you have intermediate and surge, and you learn so much about it. Then that's why I don't repeat it again in the third semester. You should basically have it down pat by now.
So do you think this exam is more difficult or the next one?
I'll know more. Like I gotta take it myself.
But just, like,
Because
subject-
what used to happen is they used to do before wheel, I guess sort of took, well, I noticed last year we changed it. But I guess like 2 years ago, JL was just coming on as full time, and I wasn't full time yet. And we had a discussion about the subject material, and I said, and she backed me up, thank God. I said, why do they have respiratory and cardiac in the same exam? It's really, really tough. I was like,
For
I don't know
final
if that's a good
semester?
idea. So that's why respiratory will be on your midterm. It's cardiac now. But they used to be two of them together. I'm like, oh my God, it's like the hardest part of the whole semester.
That is insane. Respiratory and cardiac. Oh, I'm gonna get palpitations. Jeez.
Yeah, so watch the smaller videos. Like definitely, if you don't watch anything, watch the smaller videos, because they'll definitely. The bottom line is like, is that it? It's like, okay, what you need to know about this thing or
Oh.
that thing, that kind of thing.
These smaller videos?
Mm-hmm.
Okay.
Yep.
Some additional search.
Yeah, I took like I'm not, I guess I'm not that great of a producer, but an editor. But it's just like, I guess I could have taken smaller sections of the whole video and made them smaller, but I didn't. I just.
You know, on YouTube, you
Oh,
could,
these ones.
if you
The shorts.
upload it on YouTube, you could put tabs on it.
Yeah, it's a lot of work.
Yeah.
Yeah, I don't have time to do that. I have 2 jobs. I really don't have time to do
No,
that.
that's fair, that's
I'm
fair.
like, yeah, I'm not gonna do that.
No,
I'm
that's
just gonna talk about this, you know?
I'm just gonna clip it.
Yeah.
I see.
But honestly, it's like, if you're, like, at the beginning of every chapter, there's this thing called learning objectives, right? They're also known as SLOs. So you look at learning objectives at the very beginning, and just like you have in the first module that I create for all of us do. But if you look at the SLOs in the very, very beginning, and then at the very end I repeat, it's like, okay, by now you should be able to understand this. That's a clue. You should be able to piece all that together, and if you can piece all that together, then you're going to be fine. You're going to pass the exam more than likely, and that's really the key. So I look at it this way: if you get down to the very last module, you go through, even if you don't read the book, right? Let's say you don't read the book, but you go through all the modules, right? And at the very, very end, the very last module, where it's like pulling it all together, and we have like the review. The classroom time, whatever. If you look at, I literally write, by now you should be able to understand these concepts, bullet points. So you read the bullet point and you should think, okay, what do I know about this? What do I know about that? Like, wait, I didn't remember learning about this. So then you take that opportunity to go back and find it. And then go through it. So, you know, a sense of you studying stuff you already understand, right? So that's how to, that's kind of like a little bit of a hack, how to get through nursing school. You're welcome.
I'm looking at these questions. Beefy.
I know, I used to make flashcards. I used to make flashcards, not in a sense that, like, you know, memorizing theories or memorizing words of things, but I would like literally would like write some concepts out and leave some blank words to it. And then the opposite side have the answer, like kind of like a flashcard way,
Yeah.
and try to see if I could piece it together. And then, like, a lot of times you would recognize that kind of stuff on the exam. Like, oh, I don't remember what this meant, but I remember these 2 words, right? And that kind of thing. There's a lot of rewriting, but it's just like,
I mean, that's just-
it worked for me.
Yeah.
Reinforcing. what
Everybody
you-
learns differently, right?
That makes sense.
My brain's done learning.
So what other questions do you
Second
have?
exam.
Can you think of right now that I can try to help you with? Cardiac thing was pretty good. It seemed like, you know, like it encompassed a lot of what you needed to know.
What about some?
I don't understand the mitral something. Hold on.
Mitral regurgitation,
Regurgitation.
Yeah, and then the other one.
MVR, mitral valve.
Stenosis?
Yeah, I was looking at it yesterday and I just couldn't picture it in my head for some reason. The valvular diseases, regurgitation and prolapse. I don't
Okay.
understand that.
So, alright, so mitral stenosis just basically means that the valve, the mitral valve, is just old and decrepit and kind of broken down, right? It's like having a and
60%.
so it's not as flexible anymore. It's like my skin is very flexible, right? But where it's not very flexible is here, where my scar is, right? Because it's fibrotic, right? So the valve gets really tight. So therefore, it doesn't open or close properly. It's like, so what happens then, therefore, is the pushing, you know, the thing is when the atria pump out, right? And then as it's pushing through its systole, the valves are pushing towards the, like, say this is both the AV and the SC, sorry, the mitral and the pulmonary, right? So it's just like, you know, the atria is on the top and the ventricles on the bottom. And what it's doing is it's like, it's systole, right? So it's pumping, right? Atria is pumping at the ventricles and it's pushing so that everything goes in. Now it closes off so they can push out, right? Either to the lungs or to the body, right? From the ventricles. What happens is that it's become fibrotic, right? And they sometimes can prolapse, meaning it falls in upon themselves,
Oh,
right?
okay.
Right? Or it becomes fibrotic, right? Or it's stenosed, right? Stenosed, stick a stone. When you think of stenosis, stick a stone, right? That it becomes more solid, it's not flexible anymore. And it hardly moves at all. So then what happens is all this blood just keeps going all over the place.
Okay.
So wherever anything backs up, right? So let's say if it's a left ventricle, if there's a problem in the left ventricle, then what happens is from the left atrium, that blood isn't able to move out because the left ventricle can't push, okay? And then therefore, then the lungs, right, or the fluid's now sitting inside your lung, right? Because it can't move because the left atria isn't pushing, right? Or left ventricle, yeah, there you go. So, but we'll rely a lot on the valve. So if it becomes prolapsed, or it means it curls in on itself, it just basically is collapsing, right? It's a good way of like kind of thinking about it. Or if it's stenosed, regardless, it becomes a problem, right? So when you get bacterial in there and stuff like that, that's not good. And then eventually the valve's going to have to be replaced. So if it's not replaced, then therefore you're going to have lots of systemic problems, right? So that's how COPD happens. That's how, well, I should say CH, or heart failure kind of like gets really bad because the left ventricle is not emptying, right? It all backs up in that direction because the blood's coming from the lungs to the left atria into the left ventricle and then out, right? So when you have that hypertrophy on the left ventricle, like that pressure, if the valve's not working, then that pressure increases in the left ventricle or any of the atria or ventricles, but it gets really fat, and now it doesn't want to pump as right either because it's struggling. So that's why like having like the valve and the regurgitation just means that it's just spinning
swirling.
because it can't get out because it's just flapping in the wind.
So all
There's
three
no
of those
muscle
are,
to it. There's no tone to it anymore.
all three of those
for a
could
product.
be like separate, but they could also kind of intertwine with each other, stenosis, regurgitation, and prolapse.
Yeah, they all cause the same problem.
Okay.
Yeah, they all cause the same. They all cause the same issues in the end.
Okay. That's what I didn't understand. I was like,
Yeah.
what is the difference? They all sound like they do the same thing.
They do. They're all. It's
So
just
you're
there's just
right.
different damages. Like, there's different ways and different things. Like sometimes viruses set in, can cause that. The stenosis just could be something genetic, maybe. I mean, it could be anything.
Okay. Thank you.
Yeah.
Did not
Kinda-
understand
Kinda
that.
weird.
It is.
Hope that helps.
It does. Thank you very much.
You guys all look like you're just brains are just sucked.
Yeah, I think.
Henry just looks like a big old pile of nerves. He really does.
Sorry,
You're like, oh my god.
What's your snack for?
I have no more.
Oh shit.
Oh
Come on,
my
let's go to the
God.
cafeteria.
Deep breathe and cough.
But they were strong.
It's too funny. Like my old director. My old director would be just like, she didn't have office. She got rid of the chairs in her office and would sit on a big bowl. And she was like,
She's one of those.
we would have their Zoom meetings and she'd be on her fucking treadmill.
I love that.
Okay, well, I just saw a thing on LinkedIn. They said you should never do that ever. It's really not professional. And the
Oh.
pandemic things happen, but then it's not the pandemic anymore. And
Yeah.
it's really not professional for you. They'll be holding a meeting while you're on a fucking treadmill.
But can we do that while we're
Lay
doing
does
Zoom
the
with
same
you?
thing. Lay from the clinical instructor, Leigh.
Oh, I don't think we've met her yet.
Oh, she does the same thing. She'll be
Hey,
on
if
the
you get your
treadmill.
steps
I'm like,
in.
okay.
We're back checking.
I don't suppose you can find any other time to be doing this, but okay, sure. Yeah, this is crazy.
I wonder if she retains better if she does that.
I don't know.
I can't.
Shit, I'd be out of breath on the treadmill.
I can't.
I can walk and talk like.
I can't.
I talk
Is
to
her
you.
wait Leigh Bolton?
Yeah.
Is she also an NP too?
Uh-huh.
She used to work in my clinic.
I bet.
Oh,
Yeah.
wow.
Yeah, I
right.
saw her name. She created the Pronto Shots. I was like, her name looks really familiar.
Oh.
Oh. Interesting.
Oh, wait, what clinical group does she have?
She has right now,
Walnut
her and Grace are sharing.
Oh, really?
Walnut
Did we
Creek.
ever see her?
Creek.
No, I don't think so.
Oh.
Maybe during
she'll go to
graduation.
graduation.
Yeah.
Oh,
Yeah.
Get her.
They're a Saturday,
Nice.
Sunday.
Then you're gonna be like, I'm done.
Yeah.
What else? Is there anything Ivy that we might
She
be
has a cool
doing?
story. How she became an NP.
Really?
Because she was in the pre-hospital world. She was in
Oh.
the EMS world. She was like the paramedic or an EMT. I think I don't know. I remember if she actually was a paramedic or not. Yeah, it's really interesting. She also told me, she's like, "Oh, you should get your doctorate. Like me, you should just go get it." I was like, "Yeah, I don't."
She's like a just short lady, right? Yeah. Okay. Yeah. That is
Yeah.
Leigh Bolton. Okay.
Like really long hair,
Yeah.
like super long.
I don't know if she'll remember me. Well, maybe she might.
Show a picture. Do you have a picture of you guys?
No, well, I talked to her about nursing school and NP, and she's like, "Oh, you should totally do it." Da, da, da. This is in my second semester.
She'll probably
And then she
remember
left.
you.
That was
Yeah.
from last year, right?
Yeah.
Yeah.
She's like a per diem.
You should remember you. I mean, who wouldn't remember you?
It was really short. Oh yeah. Hopefully I get to see her.
What's the difference
I feel
between
like next
tunneled
month
and
we'll be talking
non-tunneled
about respiratory.
lines?
They
But what
have
we'll
to
do
do with
is
the PIC
for
ones,
RT,
right?
Yes.
I'll have when we do respiratory,
Let's see.
I have a lot of friends here that are RT, and all this
Are
ads
they?
down on the list. Are we there?
And you
Okay,
heard
the
something
tunnel,
too? Asking for a friend.
Slide 18.
Asking for a friend. Not I. But a real friend.
a real friend.
A real Not the fake friends.
What is it?
I thought you were gonna say something about
Types, non-tunnel, tunnel, accessible.
She didn't explain that?
You
Oh.
probably will later on, but
Yeah,
this
that
is a
too.
non-tunnel. This is the one that's like outside.
Teach me how to do it.
Right.
Oh, I see.
So
Okay.
this is
Use that thing
outside,
that we
Yeah.
and the tunnel is
Inside.
inside the skin. Non-tunnel is and then it's outside.
Okay.
Freaking incentives for
It's
autism.
there
That
you
makes more
go.
sense.
Non-tunneled is outside.
Uh-huh.
Tunneled is inside.
Mhm.
Okay.
With implanted cast.
Okay.
Whereas the other one is outside, sticking.
Okay.
So slide 19
So that's like-
explains it. 19 explains it.
Okay.
I mean, if you visually see it, you kind of get it.
Yeah. I'm a visual,
It's,
like 70%
not really
visual.
beneficial
Yeah.
So what's the difference between non-tunnel and
to
tunnel?
anyone that's
Non-tunnel is
doing
outside your
ADA.
body.
It doesn't make any sense.
Oh,
It's
inside,
research,
which is
yes.
the pig and
Research that you
the.
do for
Mhm.
your bachelor's.
So peripheral
It
would
Is that
be
like what the
non-tunnel.
capstone is?
Yeah.
Capstone event?
Is it?
Yeah,
That's
you
like-
But I think
paper
it's
usually
between, it's comparing the central venous axis devices. Because there's a non-tunnel venous central device and then there's a
You can do a
tunnel
bachelor's and your master's.
central venous
Yeah.
axis device.
How long is it?
Slide
It's
19.
usually, it's like a term.
So not
paper, so
peripheral,
to
because
speak.
peripheral would
It's
be more like on the hand.
There's like a.
Which would be
So
pick
tunnel
line.
does
Which
that
would be
work?
pick line, yeah.
Essays you have to do
And that's
along the way.
non-tunnel.
And what you.
Sorry.
If you're
No,
smart
you're
enough and if you
fine.
have
I have
a
a lot
good
of stuff
mentor,
here.
No, that's fine.
then you
Ugh.
should focus your papers on your ultimate goal, right? And, so for me, I chose like, obesity and childhood obesity, so to speak. And you always pick
Bro, that's
stuff
insane.
that is easy to
I
replicate.
could, it's terrible that
There's
it's for
so
little
much
kids.
data and stuff.
I can only
it's just
imagine the pain that child
it's
was
not
going
the
through.
place to decide, oh, I wanna.
Huh?
Did you see one?
No, but I mean, she said this was a baby's hand.
To prove that.
That's what she said in the lecture,
I
that
don't
is a
know,
child's
something
hand. How did you not figure that
And
that
there's
was
hardly any
happening to that
research
kid?
on it. It's like, why are you gonna
She
make
said it was a
different?
kid,
Michelle
like
Wright,
5 years old. I can't remember.
She
It's
does
a
that
kid.
kind of shit. And then JL and I are like,
Yeah.
why
I
are
feel like
you,
it's always
why,
been like that,
why are
right?
Yeah.
you
And then
managing
like
to
post
do this?
care.
It's like, it's not the time to be,
Also for the MCT,
try
One
to
thing I
figure
don't
something
put a
out.
lot of sitting.
Like I want to get my bachelor's, like
I'm all scared.
It's easy.
Here
You
also
met
she
Sarah the other day,
mentioned
right? Okay, so her
For
sister
the
had an older boy.
TPN or something for the heart, what would you do? You would give glucose.
Yeah, I paid,
Yeah, you
I
would
paid
give
a
glucose
damn
because the
good penny.
patients,
I ain't gonna
she
lie,
had a bag
but I
of
learned a
D10.
lot.
Because the patients already received
Right,
glucose,
right,
they don't want
and
to
she
stop.
has edits it, and
have to
what she
insert
does
it.
is like she'll tell you what you should maybe
So
take
if a
this
patient's
sentence
getting a
out, right?
TPN, like, you know,
Maybe say this,
what is the
focus on
TPN?
this
The
instead,
total parental
maybe this
nutrition.
paragraph,
If it
blah, blah,
gets
blah, whatever.
lost,
Boom.
like if it
was like,
goes out
when I
and
first
stops,
started using her,
you have to
and
hang
then I
a
have
D10
primarily too, but when
to
I first started
complement
using
whatever that,
her,
until you get a new one. And then
it
you
was
switch
probably
it
like
back.
the first or
Oh.
second paper,
That
like
makes
it was
sense, because you don't have to
probably
do
the most
like
expensive.
Vogue, I
It
assume.
wasn't, it was
That's what
less
she
than,
said.
it was less than
She said
150
because,
bucks each time.
You need to monitor
Then
the
by the
growth
time
rate,
my
and then you
capstone
should hang a
came
bag of
like,
D10.
I
So
hardly
be
had to
mindful
have
the
to do anything
patient has
because
been
of
having
how
a
you
very
just
high
learn, you
concentration
just
of
learn how to
glucose,
do it.
so you cannot just stop it.
Especially
Patient,
APA
like I said,
formatting and all
patient may
that,
become
so it's like,
hypoglycemia.
Okay.
And he pretty much said that in the lecture. So I'm like, that's
you know,
what
it's not like
she's
you're doing the work,
giving us
they're
a
just
question.
helping you work.
Here too,
Yeah.
what
smart.
happens,
That's why I
having
love
us a
AI.
piggyback that
I
connected
think
with
AI
the
is
filter.
dope.
And I wrote,
I have not used
why?
it, but I know people were telling me.
Oh, yeah.
Let y'all-
You connect below the filter because the lipids are too
Yeah.
big for the microfilter, and they will occlude the tubing, which is why you see hanging below the
We
filter.
switched to a new textbook.
So she might ask a question about that.
What
To get it together.
The parental nutrition bag needs to be
We kinda
hung
tweaked
above,
our curriculum. And so
the
there's two
piggyback
new courses
needs to
that
be
were
hanged
different,
below
two
the filter.
subjects that were different
What
So
is
in
that?
addition
When
to
you guys were
TPN.
So I was like, oh, shit, I don't have an introduction to them. And AI.
Because there's a filter, so you need to hang that below.
it was like this. I'm like, boom, like 3 paragraphs, done. I was like, oh, that's freaking awesome. No one's gonna read it anyway, but hey, but it's cool. But it was like, all right, my work's done.
For your capstone?
No. I'm talking about using OpenAI, like ChatGPT.
Oh, ChatGPT.
And the other thing is, it doesn't give you references, and you really have to do the extra work.
Yeah.
But it's just like
If you know how to use it.
if you know how to use it. And then I also learned how to take a person's paper and run it through